Good evening, everyone, and welcome to our virtual world tonight where we're going to hear some more about COVID. I was hoping that by this time we'd be much more enlightened than we are. It still seems pretty cloudy out there, but we have a great panel that's going to share with us all the newest in the information that's available. So we're going to get started. Our first speaker tonight is Dr. David Rand. He is board certified in infectious disease and internal medicine. He graduated with honors from the Keck School of Medicine at the University of Southern California. He went on to complete his residency and fellowship at USC Medical Center. Having more than 30 years of diverse experience as an infectious disease and internal medicine specialist, Dr. Rand cooperates with many other doctors and specialists in the Malefchik-Rand Medical Group and is part of the Torrance Memorial Physician Network. Dr. Rand is affiliated with the National Board of Physicians and Surgeons for Infectious Disease, as well as for internal medicine. He cares for patients with infections that are difficult to diagnose and treat, many of which can be life-threatening. Our next speaker will be Dr. Elterwill. Dr. Elterwill earned his BA at the University of London and medical degree at Cairo University. He completed his residency and his pulmonary, critical care, and sleep fellowship at USC Medical Center in 2003. Dr. Elterwill is board certified in internal, pulmonary, critical care, and sleep medicine. Dr. Elterwill is a pulmonary and critical care physician also specializing in sleep medicine. He currently serves as the medical director of the pulmonary services at Torrance Memorial and is part of the Torrance Memorial Physician Network. Dr. Elterwill has practiced here in the community for over 15 years. Our next speaker is Dr. Rumi Kader. He is board certified in internal medicine. He received his Bachelor of Science in Biology and Business Administration from the University of California at Los Angeles. He earned his medical degree at UCLA Drew Medical Education Program and Loyola Stritch School of Medicine. He trained in primary care and internal medicine, where he gained greater exposure to integrative medicine, adolescent health, geriatrics, sports medicine, and men and women's health. He also holds a Master of Public Health degree specializing in epidemiology. Dr. Kader joined the UCLA faculty while serving as chief resident in internal medicine and was soon promoted to full professor of clinical medicine at UCLA. He enjoys taking care of all of his patients' needs, from simple sprains to treatment of disorders such as hypertension, heart failure, pneumonia, and diabetes. His practice style is one of collaboration with his patients, employing preventative measures to help achieve the best possible health outcomes, and it is his goal to help his patients achieve an active and healthy lifestyle. So we're going to let Dr. Rand go ahead and go first.
Thank you, Dr. Miller. I am David Rand, and I am the co-medical director of infection control and the chairperson of the Special Pathogens Committee at Torrance Memorial. And for those of you who were with us the last time that we had a Facebook Live meeting, you're probably going to hear a lot of the same stuff. We're going to go over some of the same stuff with some minor tweaks. And for those of you who weren't with us before, hopefully this brings you up to date and where we started from, where we went through, and where we are today. So it all started in February of 2020 when the COVID-19 epidemic or pandemic hit the world stage. We isolated our first couple of patients here in the United States, and at Torrance Memorial, we decided it was time to have a plan when COVID-19 would reach the South Bay and Torrance Memorial. This started with what we call the COVID Command Center, and this is a group of people that is just a phenomenal group of folks that I've had the pleasure and honor of being able to work with for the past several months. It's multidisciplinary. It comes from the administration, multiple different physicians, varying departments in the hospital, lab, micro, and so on. And it's just been a remarkable group of people to work with. And with the forward thinking of these people, what we were able to do is come up with a response to COVID that was seamless in truly an ever-changing environment. Literally, it was changing every day. We had new guidelines on a daily basis, new treatments, no treatments, and it was a difficult thing to keep up with at that time. What we ended up doing is we started with the emergency department, and we divided it into COVID and non-COVID sides so that we could properly triage those people that were suspect cases and keep them apart from the people who were non-suspect cases. That allowed our ED to treat COVID and non-COVID patients and remain a full functioning emergency department. And across from the ED, those of you who have been at our institution during this time, you may have remembered the large triage center that we had in the parking lot. That was also part of what we developed during the first few weeks and months of the pandemic, and thank gosh we didn't have to use it, but we prepared for the worst and hoped for the best. We also developed or designated floors of the hospital that were COVID specific. So we would take our COVID patients and that's where they would be treated. And they were staffed by nurses who were specially trained in infection prevention and taking on and taking off our PPE and caring for you or your loved ones on a daily basis. We also worked very, very hard to secure our in-house testing capability, and that was a very important milestone for us to reach. Initially in the COVID pandemic, if you needed to test somebody for COVID, you did your swab, but you sent it to an outside lab. And that turnaround time at best was 3 or 4 days, and at worst was up to 9 days. And so when we finally got our in-house testing capability with our platforms that we already had, we were able to rapidly identify COVID positive patients and place them in the appropriate places within the institution to care for them. We also developed our drive-through testing center, which helped our outpatient physicians be able to test for COVID in those folks that they were caring for that didn't need hospitalization. And then finally, for what we've done, when we started opening for elective surgeries in mid-May, we developed a program by which all those people who are going to get elective surgeries also get tested for COVID prior to the surgery so that we could maybe find those people who were asymptomatic and still had virus so that we could appropriately treat those people. All of this is really to say that our primary focus at Torrance from the get-go was patient safety and staff safety. We wanted to make sure that those people caring for our COVID patients and COVID patients themselves were taken care of at the highest level and that we would not be infecting other people. And we've really done a great job of that. To date, there are no known positive patients who have gotten COVID from other patients in our institution. There are no known positive COVID patients that got COVID from our staff. There are a handful of staff members that may very well have gotten COVID from patients, but it literally is only a handful. So what I really want to stress here is that if you need hospitalized care, Torrance Memorial is a very, very safe place to be, so don't hesitate to come. So COVID in the South Bay. We treated our first patient on March 10th, followed by a large surge, and it peaked in mid-May, followed by a decrease till about Labor Day, or till about Memorial Day. After Memorial Day, we started seeing an increase, but this wasn't unexpected. You know, the country was opening, and so was our state, and so we expected to see a few more cases than we had been seeing before. Unfortunately, what ended up happening is we saw far more than we had expected. So Memorial Day happened, then the social unrest in June, followed by the 4th of July holiday, gave us yet again another surge from July 8th to July 16th that literally was as bad as what we were seeing in April. We were seeing the same number of patients on a daily basis, and our hospital average was the same as what we saw in April. There were few differences, though. In the first surge, what we saw were patients who were coming back from travel. They come in, they would be with their loved ones and go to parties. And at that point, we weren't masking and socially distancing. And so that was a population that we ended up seeing. The second group, if you will, was a nursing home population, and that was a pretty significant portion of the patients we were seeing initially. And mostly they were greater than 65 years of age with multiple comorbidities. The people that you would expect as the most vulnerable people that we heard of from the beginning. On our second surge, however, the age range definitely changed. We were now seeing 30s, 40s, and 50s as the primary focus of the patients that we were treating, or primary age groups of the patients we were treating. And when you took histories from these people, there was really a very common theme. And it started in post-Memorial Day, and people were saying, I'm tired of being locked down, I'm tired of wearing masks, I want to see my family, I want to see my friends, I want to go out and have a good time. Perfectly understandable. However, I think their guard got let down. And so what we were seeing is there was not as much masking, certainly not as much social distancing, and we all saw that on the media in parties and beach parties and the whatnot. And that all came to fruition in mid-July, mid-July. The month of July was a busy month, so we didn't see as quick of a slowdown as we did in the initial phase of our surge in April. But now in August, we're seeing a significant slowdown, and we've gotten back to basically the same plateau numbers that we saw in May. Now, I'm sure the repeat lockdown had a lot to do with that, but I also like to think that maybe people are becoming a little bit more aware, and that masking, social distancing, and washing hands is an important measure in keeping themselves and others safe, and I'm hoping that that's part of what we're seeing in terms of the decrease in cases right now. So COVID-19, what is it? Well, COVID-19 is actually the disease you get from the virus SARS-CoV-2. I know, a bunch of fancy words and really only mean things to us. But SARS-CoV-2 or COVID-19 is contracted through respiratory droplets. And what that means is that you are with somebody, both unmasked, and they are talking, sneezing, or coughing, and they develop a respiratory droplet, which you then inhale or get into a mucous membrane such as your eye, and the virus can then replicate. We have other coronaviruses that we see seasonally as well, and they cause the common cold, and there's 4 of them. The difference between those coronaviruses and SARS-CoV-2 is that they remain in the upper respiratory tract. Yeah, they cause sneezing and runny nose and snuffles and all of that, but that's where they remain, upper respiratory tract, where SARS-CoV-2 gets to the lower respiratory tract and causes pneumonia. It doesn't stop there, though. The actual replication of the virus is important in terms of disease pathophysiology, but it's more the human host's response to that infection that causes the significant disease. So in other words, your body develops all of these chemicals and all of these white cells and T cells and whatnot to try and eradicate the infection, and it goes way overboard. And we call that a cytokine release storm or cytokine release storm. So a lot of our therapeutics are divided into two different ways of treating. And one is antiviral, and the other is to try to blunt the cytokine release syndrome, if you will. So then that brings us to what we do now in terms of therapeutics. Not much has changed since the last time we talked. So we've got a triad of medications that we use in the appropriate patients, and it's all determined based on lab results and their oxygen requirements and so on. But it starts with remdesivir. You guys have all heard about it. And that's the antiviral component. So if somebody comes in the appropriate period of time after onset of illness, we can give them remdesivir and we can cut their viral load. What it's been shown to do is decrease the time of illness by about 4 days. So from 12 days on average down to 8 days. There's a nice trend that it reduces mortality as well. But it's only a trend. It hasn't been statistically proven, so we can't say it with any definitive words, but we do believe that it decreases mortality, even though it's not been statistically proven. The next is convalescent plasma, another thing you guys have all heard about, I'm certain. And what that is people who have recovered from COVID donate their blood, we separate the cells, and what's left is liquid called plasma. We give that to a COVID positive patient. The theory being is that there are antibodies within that plasma, anti-inflammatory agents, maybe, that's very controversial. But plasma has been shown to, one, help people get better quicker and reduce mortality. There's a whole lot of controversy in the numbers and mortality decrease, whether it's relative risk or absolute risk, and that's certainly a talk for another day, but it does help. And then the last of the triad, if you will, is steroids. We use Solumedrol here at Torrance Memorial, and what we're trying to do with that medication is blunt that horrific immune response that is what's causing all the damage to our lungs, kidneys, liver, and so on and so forth. Another piece of our treatment protocol also is anticoagulation. So we've done a lot of autopsies on patients who have passed of COVID. And one of the universal themes that we see is that there are these microthrombi, or little clots, in all of these end organs, their lungs, their liver, their kidneys, which deprives that particular organ of blood and also causes damage. So if we anticoagulate, we're hoping to be able to reverse that as well as prevent that from occurring. There are a multitude of other therapeutics that are being looked at in randomized controlled trials, much of which is not available to us as yet. My group and the Pulmonary Critical Care Group, which Dr. Eltewell is a part of, are involved in 3 clinical trials here at Torrance. One was with convalescent plasma. Looks like that study may be changed a little bit with the recent FDA authorization of plasma for anyone. The other 2 studies involve other immunomodulatory agents that we are targeting pieces of the immune system, once again, to try to blunt that inflammatory response that COVID induces. So kind of where do we go from here? Well, it's interesting. We've got another holiday coming up. And if our last 2 holidays are any indicator, we should be seeing a surge between 2 and 4 weeks after Labor Day. But back to what I said before, if what we're seeing now in terms of reduction of number of COVID cases is actual awareness by the public that masks, social distancing, and hand washing works, we don't have to see that surge. We really don't. And I can tell you that that is the only way that we know of at this point to prevent and mitigate the spread of COVID-19. So please, please, please wear your mask. I know it's a pain in the butt. Social distance, also a pain in the butt. But if we can put up with a little bit of inconvenience for the next several months until we get a vaccine, it's going to go a long way into preventing deaths and other people from getting sick. And finally, I want to thank everybody that I've been having such a pleasure and honor of being able to work with in this institution. From administration all the way down to food service people, and a special thanks to my nurses. I believe I've got the best nurses in the world. I know I'm biased, but you guys are the ones that allow me to do what I do on a daily basis, and you guys are the true heroes of our institution. With that, I will pass the stage to Dr. Eltewell.
Thank you very much, Dr. Rand. Thank you, Dr. Miller, for having us here. It is truly a pleasure to be here with you tonight. I agree with everything you said about the workers here in the hospital, and particularly the nurses. They truly support us, and they make our work, make us look as good as we do look right now. So Dr. Rand summarized COVID-19 in a very good way as far as the hospital's response, Torrance Memorial's response as to what we've been doing. I will be talking about the COVID-19 as how it relates to the respiratory system. So as far as transmission goes, like Dr. Rand mentioned, the virus is transmitted from an infected person, usually carried in these droplets where the infected person is talking, and the droplets come out of the mouth or the nose, and they transmit through the air. So if there is a infected person in the room, and that person is just regular talking, the virus comes out in these droplets, and those can go out as far as 6 feet out, and if you happen to be within that vicinity, it's very easy for that virus to land in your mouth, in your nose, and as Dr. Rand mentioned, can actually go all the way down to the lower respiratory tract. The closer you are to the source of the infection, the more virus you're probably going to get, and the more likely it is that you will be sick. If this person is doing some more forceful breathing, like coughing or sneezing or yelling, it is very possible that these droplets can transmit even further out than 6 feet. Eventually, these droplets start settling down, and they settle on surfaces around you, on the tables, on the phones, and a healthy person who is not wearing gloves, for example, can pick up any of those surfaces and can pick up the droplets on his hand, and by rubbing your eyes, your nose, your mouth, these droplets full of virus can go inside and start causing infection as well. Once a healthy person does get the virus load in them, their symptoms can vary quite a bit. So the vast majority of these patients will either be asymptomatic, show no symptoms at all, or may have some mild symptoms, cough, sore throat, a little bit of shortness of breath, and usually this persists for a few days, maybe a couple of weeks, and then eventually resolves. Some patients, particularly since this virus does go all the way down to the lungs, may develop pneumonia, which I'll talk about in a second, and if it's quite significant, may develop what we call a respiratory distress syndrome. As Dr. Rand mentioned, this virus also affects lots of other organs in the body, and you could have what we call a sepsis picture, where just a large systemic inflammation in the whole body. One of the things that it seems to be characteristic to this virus is is producing blood clots in the system, not only in the respiratory system, but all the other organs as well. The end result of any of those infections is that the patient's oxygen level can become really low. It's what we call hypoxia. So if you look at the respiratory system on the slides in front of you, the airways start from the mouth or from the nose. They go all the way down to the chest and eventually end up in all these small air sacs at the end of the airways. These air sacs are covered by a network of blood vessels. And what happens here is the air sacs are full of air, and the oxygen gets transmitted from these air sacs into the blood vessels, and carbon dioxide gets released into the blood, into the air sacs. For this system to work, you need an intact air sac and good circulation around these air sacs. Now, what happens with COVID is, particularly when it leads to a pneumonia, is that the membrane covering these air sacs, the integrity of this membrane gets damaged, and these air sacs fill up with fluid. So it's very hard for oxygen to reach the blood vessels at that point in time. Now, if a lot of these air sacs get involved like that, then you can have a patch of pneumonia, as you see in this X-ray. And as we know, this is a respiratory virus, so you breathe it in and it goes to both sides of the lung. So it's very common for us to see pneumonia involving more than one lobe, sometimes both sides of the lung. And at the last slide on the right there, you would find that this is an X-ray showing the whole lung involved, and these patients are usually pretty sick, and that's what we call respiratory distress syndrome. A large number of these patients will end up on ventilators. One of the things that we see a lot with COVID-19 is that the oxygen level is quite low. These patients become very hypoxic. Interestingly enough, the majority of the patients that are hypoxic like that are usually quite short of breath, but specifically with COVID-19, what we found is that some of these patients have really low oxygen levels and they don't exhibit many symptoms. In fact, some of them don't even feel short of breath and don't show that they're quite hypoxic. So one of the things we do frequently is check their oxygen levels and monitor that throughout their hospital stay. For patients that end up not staying at the hospital and go home, we usually advise them to obtain one of those pulse oximeters that measures their oxygen level, because sometimes they may become really hypoxic without knowing that their oxygen level is low. In addition to all the medications and the treatment that Dr. Rand described, one of the things that is really important we do is to supplement the oxygen for these patients. Most of the time, we're able to get by using a small nasal cannula or a face mask. These provide enough oxygen to support the patient until they recover and eventually are free of this cannula or face mask. In some cases, we may require more aggressive treatment, and we do have a larger nasal cannula that provides high flow oxygen and sometimes at a very high percentage of oxygen, and that is used to supplement the patient until they recover. We've noticed also that if you have these patients sleep on their stomach to prone, it can help with their oxygenation. And the idea here is that you have all these air sacs at the bottom of the lung that are squashed and compressed, and they're not open enough to allow oxygenation to happen. So if this patient were to sleep on their stomach for periods of time, then you allow these air sacs to open up and you're allowed more oxygen flow into the body. We even do that for some patients on ventilators as well. If you're not able to sleep on your stomach, sometimes sleeping on the side for periods of time also helps. A ventilator essentially is a machine that sits next to the patient, connected to a tube that fits inside the patient's mouth all the way down to his lungs. This machine does all the work of breathing, supplies all the oxygen you need, and it's usually kept there in place until the patient improves and is no longer requiring this mechanical ventilation, and we eventually take it out. If we talk about what factors there that cause or determine how sick a person gets or what kind of lung damage the person will develop, the first thing we'll talk about is disease severity. It makes sense if you get really sick, you're more likely to have more lung damage than the patients who get milder infection. Several health conditions can predispose you to become sicker. These existing health conditions, they don't make you more likely to catch the infection, but if you do catch the infection, you're more likely to be sicker. So for example, people with COPD or asthma or emphysema, some heart problems, and the older population are more vulnerable to become more sick should they catch the infection. And also the treatment, what kind of treatment you receive and how quickly you get it will determine how much lung damage you might end up with at the end, if any at all. You can do your part to try to decrease how sick you get or to catch infection at all. So one of the things I like also is to talk about is smoking. Smoking and vaping. It's very important to stop smoking if you do, and vaping as well. Smoking and vaping, they produce irritants that irritate the airways, produce a lot of mucus inside the airways, and also they cause damage to permanent damage to the air sacs where all the gas exchange occurs. So if you do smoke or you do vape, it's important to stop. Exercise is very important, I'm sure, and I'm guilty of that myself. Since the pandemic started, a lot of us are staying home. We're not exercising as much as we did. Exercise is important because the more you exercise, the more you expand your lungs. It also improves your immune system, and you're able to fight infections even better. Reducing mucus buildup in the body is very important. So mucus is a normal substance that develops in our bodies. We see it in the airways, we see it in the nose, we see it in the lungs. Anything that irritates the airways, the nasal airways or the lungs will cause more mucus to be produced. If there's more mucus, mucus in itself acts as a breeding ground where bacteria and viruses can grow, and in addition to that, it can block airways and prevent gas exchange and oxygen going back and forth. In addition to the airways, in the lungs as well, some conditions, so for example, people who have asthma, if the asthma is not well controlled, there's a lot of mucus buildup inside the airways, which again causes a breeding ground for bacteria and viruses, as well as prevents and blocks airways. You can help decreasing this mucus by minimizing exposure to allergens. So for example, cleaning the air ducts in the house, applying a filter if you have one at home. If you are prone to allergies, make sure you're taking your allergy medications. This achieves two things. One of them is that it helps decrease the mucus production, but in addition to that, if you happen to blow your nose or cough and your hands are not clean, you could help transmit the virus very easily to yourself if you had touched a surface with a virus on it as well. The last thing I'm going to talk about is sort of the long-term effects that you can end up with if you do develop COVID. So the bulk of the patients, the vast majority of the patients, will likely fully recover in the first couple of weeks with no residual symptoms at all. The patients who have a little bit more severe infection can end up lingering for up to 4 or 5 or 6 weeks with some symptoms like cough or shortness of breath. We do see a lot of lingering symptoms if you do have a serious infection, and those can last for a while. We've been now with the COVID for about 5 months or so, and I do still have some patients 5 months later with some symptoms. And it's important to understand that the lung tissue and the muscles can take some time to recover. Some of these patients end up getting discharged on oxygen. Some need physical therapy, some need emotional therapy, some need inhalers and so forth. It is a little bit early at this point to talk about scarring of the lungs, but it is a concern that we have that some of these patients may have permanent damage to the lung, permanent scarring to the lung. It depends on how healthy the lungs were beforehand. So if your lungs were all the way healthy before you developed COVID-19, it is possible that you may have some scarring in the lung and not feel any effects of that at all. If you started out with compromised lung, like people have COPD or asthma, and you do develop some scarring, you may end up having worsening symptoms over time. We are still not sure how long that would be and how chronic these symptoms would be. In addition to lungs, of course, there are other organs that can leave long-standing effects or lingering effects, and those affect the heart, the brain. A lot of psychological issues can persist after COVID-19, and what we're seeing as well now is chronic fatigue, where you just feel tired lengthy periods of time even after recovery. I think I'll stop right here, and I'll pass that on to Dr. Cater.
Good evening, everyone. I'd like to thank everyone for joining us this evening to listen to our presentation on COVID and influenza. So I'm going to be talking to you a little bit about influenza. One thing is we're really concerned about this particular flu season that's upcoming because of the presence of COVID at the same time. The big difference is here we have a vaccine, so I really want to emphasize from the beginning we can prevent influenza at this point with vaccinations, something which we're direly waiting for in terms of a COVID vaccine. So what is influenza? Influenza is a contagious respiratory illness caused by the influenza virus. It can infect the nose, throat, and sometimes the lungs. And symptoms can vary from mild symptoms to severe illness, and sometimes it can even lead to death. Once again, the best way to prevent flu is by getting a flu vaccine. Unfortunately, flu vaccines need to be taken on an annual basis because every year the virus mutates, and as such, the vaccines are developed for the most common types of influenza that will come out in any given season. So if you had an influenza vaccine last year, you would still need to get one for this season. Flu viruses are most common during the fall and the winter, but influenza activity typically begins to increase in October. What are the signs and symptoms of influenza? Fever, chills, or feeling feverish. Not everyone with influenza develops a fever. A cough, sore throat, runny nose, stuffy nose, muscle aches or body aches, headaches, and fatigue are also symptoms of influenza. Some people may have vomiting and diarrhea, which actually you can also see in COVID. What is the burden of influenza? Influenza is not a benign disease. A lot of people think that influenza is just a simple old bug like a common cold that everyone recovers from. Not so. Typically, we have about 30,000 deaths a year in the United States. In 2018 to 2019 flu season, CDC reported 34,000 deaths in the United States with 490,000 hospitalizations that same year. That's a lot. How does flu spread? Very much like COVID, spread mainly by tiny droplets made when people with flu cough, sneeze, or talk. These droplets can land in the mouth and noses of people who are nearby, and therefore people can get infected that way. Every year, about 8% of the US population gets sick from the influenza virus. The range can be between 3% to 11% in any given year. In terms of period of contagiousness, people with flu are most contagious in the first 3 or 4 days after their illness begins. Some otherwise healthy adults may be able to infect others beginning 1 day before symptoms develop and up to 5 to 7 days after becoming sick. Onset of symptoms is the time from when a person is exposed to the virus and infected with flu to when symptoms begin. Typically, it's about 2 days, but can range from about 1 to 4 days. Complications of flu can include bacterial pneumonia, ear infections, sinus infections, and worsening of chronic medical conditions such as congestive heart failure, asthma, COPD, and even diabetes. Some people are at higher risk from getting influenza, typically people age 65 and older. Those with chronic medical issues such as lung disease, such as diabetes, asthma, COPD, and heart disease. Pregnant women and children younger than 5 are also at increased risk of the worsening complications of influenza. In terms of preventing seasonal flu, the first and most important step is to get a flu vaccine. Flu vaccines reduce flu-related illness and the risk of serious flu complications that can result in hospitalization and death, as we talked about before. Timing of the vaccination is important. Typically, the CDC recommends getting vaccinated in October so that you don't develop a early, how would you say it? If you get it a little too early, you may not have that optimal response in terms of when the flu actually hits in October through February, typically. Today, the CDC website actually says consider getting the vaccine in September, which is right upon us. So I would recommend at this time getting it in September, although the optimal time of vaccination in the past has been recommended to be October. Now, can you treat flu? Absolutely, you can treat flu. There are medications such as Tamiflu and Relenza, which can be used to treat influenza. Typically, we like to see those patients within the first 48 hours of symptoms, as the medications are most effective at that point. In terms of diagnosing flu, there's different ways to diagnose. Typically, we go by symptoms. There are office-based tests, such as a rapid flu test that can be taken to tell someone rapidly in the office this patient has influenza A or B. There is a significant amount of false positive and false negatives with this, and as such, if someone is hospitalized, a send-out test might be done which has much more accuracy in terms of the sensitivity and specificity of the test. So once again, my big impetus of speaking tonight on influenza is most definitely for people to get vaccinated. If we get the vaccination rates up high enough, perhaps we can really prevent unnecessary burden on the hospitals, the clinics, and especially with COVID being around, we really do not want people to have both COVID and influenza co-infections. So please, everyone out there, try and get your vaccines starting up next week. Thank you.
Thank you very much, panel. Now we're going to go to the question and answer portion. We've been collecting some questions while the panel was speaking, and so we're going to address these to the panel now. Dr. Rand, does Torrance Memorial offer rapid testing to anyone who wants to be tested?
That's actually a very good question. The answer to that is no. And as I had discussed earlier in terms of our ability to test, it really also has to do with our supply chain. And what it comes down to is Torrance Memorial's allotment for in-house rapid testing has to be restricted to those people coming in through the emergency department that we need to determine whether they do or they don't have COVID. So no, if you're a general public person and you want to come to the hospital to get a COVID screen, that won't happen. What you can do is you can certainly call your primary care physician, who may be able to refer you over to one of the public health collection centers where they are doing screening on anybody. Or if you have symptoms, we do have the ability to do outpatient screening through our drive-through center that's located behind the specialty building on Lomita Boulevard.
And just from the primary care perspective, I get questions like this every day. And what I've been telling people to do is what I tried. I went to Google and I typed in COVID testing in Torrance. It lists the LA County site, but it lists all of the CVS's and all of the other places that are doing testing. And I will echo what Dr. Rand mentioned earlier is there's such a demand on the system right now that you can go for a test and who knows, it may be 1 or 2 weeks before you even get a result. And this is causing some problems. We have employers that are saying if their employee had a positive test, they have to get a negative test before they can go back to work. I think there's a lot of confusion about if that's really necessary, but it's a frustrating time for everybody in terms of getting testing, but that is definitely a resource that everybody has access to. All right, this is going to be for the panel, I believe. Are COVID symptoms different for children than adults? What is the youngest patient that has been seen with COVID?
Well, I can say that when you look in general at children with COVID, they tend to have a much milder cold type of symptom. And they still have the same amount of virus. When we've done multiple studies in terms of their viral load, and even though they have markedly less symptoms, they still have the same amount of virus, and we presume the same capability of transmitting it to other people. So that does pose problems with school openings and so on, but I'll leave that to those experts. The youngest patient that I personally have treated, and this really was a wonderful success story, but I think also goes to an important point, was a 21-year-old young lady, and she was otherwise very healthy. And she came in, I looked at her, I got my history, and within 6 hours she was on a ventilator. And from there, she ended up going on what's called ECMO. And ECMO is basically a machine that bypasses the lungs and breathes for you so that the lungs don't have to. She was literally a hair's breadth away from being one of our statistics. Luckily and thankfully, she was able to walk out of the hospital a couple of weeks ago. Really is a great success story, but more to the point, those people who might be younger who are listening to this, yes, you can get sick, and you can get very, very sick. So this is a non-discriminatory illness, and you just don't know if you're going to be that person. So please protect yourself by masking, social distancing, and hand washing.
And just to add to that story, that is the youngest person that we have seen here, that I have physically seen as well. But it's important to realize that these patients can come in and they feel somewhat short of breath in the morning, and by nighttime they're on a ventilator. COVID can progress that fast, and we have seen it progress that fast.
Dr. Cater, will the flu shot help prevent COVID?
Unfortunately, the flu shot cannot help prevent COVID. It is specific for the influenza virus and not the SARS virus that's out there that causes COVID-19. We certainly hope that we have a vaccination for COVID-19 soon, and there are some very promising candidates that are out there that are being developed at this time. So unfortunately, the influenza virus will not prevent COVID.
All right, panel, the $64,000 question. How soon are we getting a vaccine?
So right now, at least when we first started with looking into vaccines, there were about 120 different companies that were looking into vaccines. Right now, there's about 5 leading contenders, 3 of which I know of now are in phase 3 trials. And what a phase 3 trial means is they've gone through all of their initial safety and dosing data, and now they're giving it to the general public to see if it works. I'm not entirely convinced we're going to have a COVID-19 or SARS-CoV-2 vaccine by the end of the year or the beginning of next. It would be wonderful if we did. I'm looking more towards maybe the end of March So I think we're gonna have to get through this flu season before we're gonna actually see a vaccine. Now, that's just my opinion. I could certainly be wrong, but that's my opinion. You guys?
I agree.
Unfortunately, I think we all have to agree on that one until we get some concrete evidence of a good vaccine that's safe, most importantly, that it's safe for all of us.
Dr. Eltewill, if a patient has a history of sinus infections, are you at higher risk to get COVID?
That's an interesting question. So sinus infections are characterized by a lot of mucus production. And as I mentioned in my talk, mucus just being there can act as a breeding ground for viruses and bacteria. So it makes sense that if you do have a lot of sinus infections, you are more likely to either develop COVID, or the way I would think about it, if you do develop COVID, you can get sicker.
I would also like to add to that, too, that I think Dr. Eltewill's right in terms of being able to possibly get COVID more easily, insofar as we know that sinusitis and acute sinusitis, about 96% of the time, that's a lot, 96% of the time is virally mediated anyway. And so COVID could certainly be one of those that could do it.
And also another addition, people who have frequent sinus infections, as Dr. Rand mentioned, it could be different viruses, could be a bacteria. And at this time, when we have someone who comes in with respiratory symptoms, we tend to check for COVID, and we may have a positive COVID test, but that does not necessarily mean that that's what's causing the infection at this moment. It could still be a concurrent bacteria at the same time.
And again, from the primary care point of view, we know that our skin protects us from infection, but we forget that the mucous membranes of our body are a very important part of protection from infection. So when you smoke, you inflame these mucous membranes so they're not as effective. And then, of course, if you have sinusitis or inflammation of the membranes, then they're not going to protect you as well as an intact, healthy membrane. This will be for the panel. Should people continue to get other vaccinations, such as the shingles?
Absolutely, yes.
It's interesting that that question came up. Today I had a patient who I recommended getting the Shingrix vaccine, and she absolutely did not want to get it because she was afraid she was going to get fevers, which that vaccine can give you. But we really recommend getting all your routine vaccinations to prevent the usual illnesses that can come about at any age. So whether it be your Pneumovax, your Prevnar vaccine for some younger patients, we really recommend getting those vaccinations, including the shingles vaccine.
I think just to add on that, one of the things that we have noticed over the last few months in dealing with COVID is that a lot of patients have put their health on hold waiting for COVID to pass. And that not just vaccination, but also other conditions, your cardiac health, your pulmonary health, and so forth. And I think it's really important to maintain your health and take care of all your vaccinations and do all your screenings just as if COVID was not around.
Dr. Eltewill, is it a myth that the mask hurts the wearer and decreases oxygen levels or increases their susceptibility to COVID?
I have heard that as well. I would say yes, it's a myth. There is no data whatsoever that tells us that wearing a mask will decrease your oxygen level or make it hard to expel carbon dioxide, for example. The mask is uncomfortable, and I think we all agree with that. And if you are in a business where you have to wear it all day long, it can become a hassle. But there is no data to suggest that it will make you sick. I guess the only thing that I would comment about is that if you're wearing a mask and there is someone who is not wearing a mask around you and that person is sick, it is conceivable that these droplets may land on the surface of your mask, and if you handle your mask with bare hands, then it is very possible that you do get these droplets full of virus on your hands, and if you end up rubbing your nose or your mouth or your eyes, then you can possibly transmit the virus that way. So when you do take a mask on and off, it's important to always wash your hands. I guess the point I'm saying is that the mask is great to put on, and I think I totally agree with Dr. Rand here. Please wear your mask all the time, but that does not take away the importance of social distancing and hand washing.
Dr. Rand, can the virus that causes COVID spread through pools, spas, and kids' playgrounds?
So the answer to that question is somewhat difficult. As far as the actual pool, a playground, which is actually kind of a unique environment, we don't really think so. However, so it's the kids congregating. That's the big deal. So when you get a bunch of people together, whether they're kids, whether they're teenagers or adults, and they are congregating in close proximity to each other without masks, that's where COVID is at its best, and it's easiest to transmit that way. Is it going to be transmitted through a chlorinated water pool? Probably not. One could certainly conceivably think of a playground with a bunch of kids possibly sneezing and coughing into their hands and then climbing on equipment, being able to pass it that way. Certainly possible. We think that fomites, which is what that's called, are less of a transmissibility issue than we first thought that they were, but by no means does it not happen. So when thinking of transmission of COVID, you really need to think about groups of people congregating together closely without masks. That's how it happens.
Dr. Cater, how do we get treatment for COVID if not hospitalized? Will my doctor give it to me?
Good question. Currently, there are no outpatient treatment algorithms for COVID-19 in the outpatient setting. If someone has COVID and their symptoms progress to an extent where they're in respiratory distress or having severe symptoms of chest pain, things like that, we send them to the hospital where they are taken in by the emergency room with special protocols and then admitted to the hospital. But there is no outpatient treatment algorithm at this time.
And just to kind of follow up on that, if I have a patient that is having some mild chest symptoms, they may benefit from an inhaler. Sometimes we'll use a steroid if you have asthma. So there are some treatments that go with particular conditions. But all of this that you'll hear on the lay press and every place else about zinc and hydroxychloroquine and Zithromax, none of that's been tested or proven. So essentially, if you're not sick enough to be in the hospital, we're going to treat you symptomatically. Tylenol, Advil for your aches and pains and headaches. Staying at home and resting. So there are pretty much just treating this like you would a common cold. How safe is it to get surgery done right now?
Well, as I said in my initial talk, surgery at this point is very safe, and specifically at Torrance Memorial. That's the only institution I can actually speak to, but the protocols that we have taken specifically in the operating room for preoperative testing for COVID, and then for postoperative care and how we manage the patient and move the patient throughout the institution, we have yet to see anybody get COVID from being in our hospital. And so I would have to say that surgery, elective or otherwise, at Torrance Memorial Medical Center is incredibly safe.
And I think the panel will agree with me. Anything that you're getting done now in the hospital, getting x-rays, getting surgeries, getting scopes, going to physical therapy, all of the protocols are strictly mandated and followed. And I feel it's much safer here than going to any grocery store where people have handled things and put them back on the shelf, and you have no idea what is on those things. All right, a patient says, I'm working with someone who tested positive for COVID, did the 14-day quarantine, and came back to work. We share the same room 8 hours a day. How in danger am I?
So I guess that comes back to me again. So the initial way that we use to clear patients, for lack of a better term, of COVID is, as Dr. Miller had described with some workplaces, we'd require 2 negative PCR tests. Well, what we've come to find out is that people will shed virus, non-viable, but shed virus and pieces of virus that are picked up by our PCR platforms quite easily for up to 90 days. So that means you get COVID, mild or otherwise, and you can actually get a PCR positive test for up to 90 days after your initial symptoms. So what we've done at this point is we've moved to a time-based strategy because we know testing just doesn't really give us the answer. And this has come from a lot of data in terms of antibody production and when that occurs and when viable virus actually goes away. And so the initial 14 days was actually very, very good. I can tell you with confidence that if they have completed their 14-day protocol and they are no longer sick and no longer have fever, your risk of infection with COVID is minimal. I won't say never because you can never say never in medicine, but is truly minimal. So much so that we've even reduced the amount of time from 14 days to 10 days in terms of quarantining people and taking them out of isolation.
Okay, Dr. Cater, if I get the flu shot now, will it last me the entire flu season, or should I wait until November and December?
Great question. We don't want you to get it too early because it may not last as long. That being said, I would not wait till November or December. I would recommend what the CDC is currently recommending, getting it between September and October. Great question.
All right, this is for the panel. What is community spread?
I guess that would mean catching the virus through being in the community, whether you're in a place where someone is sick and there's a gathering somewhere and it spreads that way, unless I'm misunderstanding that.
Yeah, I would completely agree with that. I mean, initially, the first few cases that I saw in South Bay were patients that had traveled to Italy and China and come back. However, subsequently, when we got into late March and April in the South Bay, I think we started to see a lot of community spread in our actual South Bay community, not brought in from others outside because we were passing it on amongst ourselves in our own community.
If I have or had cancer, am I at higher risk?
Yeah, I touched a little bit on that in my talk. Yes, if you do have or had cancer, you are not at a higher risk to catch the virus, but if you do catch the virus, you may be at a higher risk to become more sick than someone who does not.
You did, one of you mentioned something about a lot of the things that we've heard about blood type and can you take Advil and can you be on ACEs and ARBs. We talked a little bit about this last time, but I'll just ask the panel to respond to that. I get these questions almost every day in the clinic.
Those actually are very good questions because the misinformation, I suppose, is still out there. So we've done a great deal of work and a great deal of study specifically on those medications. So Advil or ibuprofen in no way, shape, or form harms you in taking it. It doesn't give you any better benefit with the exception of maybe being a better fever reducer and muscle ache reliever, but it in no way, shape, or form harms you. The whole thing about ARBs and ACE inhibitors, which are usually antihypertensive medications or congestive heart failure medications, because the virus uses a receptor called ACE2, it was initially thought that these medications potentially could harm people if they continue to take them. Once again, extensive study has been done with these medications, and it is actually recommended that if you are on them, that you continue. If they are the best medication to use for any given illness, that they are to be administered and written for. and they do not harm you in any way, shape, or form.
Can you get COVID more than once?
I guess that's the million-dollar question right now. It's I guess in the news in the last couple of weeks, it is thought that there is one or two people who have had a second COVID. There's been one case in China, supposedly with 2 different strains of COVID. So I think we still are waiting on a lot of data to confirm that. I guess my answer would be I don't know, but I guess it's possible. Any thoughts, Dr. Rand?
I would say that the cases that Dr. Eltwell had discussed are certainly well known to us, and the particular Hong Kong case where the individual appears to have been infected with 2 different strains of virus. There is essentially there's a Chinese strain and a European strain. That patient appears to have gotten the illness again. But what's important to realize, at least with that one individual, is he was very, very mild. In fact, if I'm not mistaken, he may have been asymptomatic and was tested as part of another study that was ongoing, and this was his normal routine test. So my feeling on whether you can get infected with COVID again is that, yes, some people likely can. Again, you can never say never in medicine. I think the vast majority of people who have had COVID are very, very unlikely to get infected again, at least within the first 6 to 12 months. After that, it's quite unknown.
And as of right now, we know of no case that had the same strain twice.
This question is interesting. Are home tests accurate? I'm not even sure if there are home tests.
I wish we had Dr. Kunesh here. He's our testing guru. I think the one that I would like to speak about the most is the new saliva test, and that's the one that's probably going to maybe even revolutionize testing, because it's going to be so easy to administer. You can hand it to somebody and they can take it home and administer it themselves, essentially by spitting in a test tube. It won't require somebody else to administer the test. There won't be PPE involved. And when we look at the data on at least the saliva test, it looks equally as good as our nasopharyngeal swabs. When all of those folks who have been tested for COVID, we like to call that the brain biopsy, because you got to get that swab way back in there, and it is a very uncomfortable test. But the new saliva test very well may mitigate that. The initial FDA authorization has already come out, and when we look at it compared to our traditional testing platforms, it looks like it's really good. As far as a true home test goes, I'm not aware of any, but that doesn't mean there aren't some that are being marketed. I'm not sure I would trust them.
Entrepreneurship and capitalism is alive and well in this country. I'm going to have one last question for this panel, and I'm going to ask them to put on their thinking caps. We're all anticipating the saving grace of a vaccine. And I've struggled with this because I wonder what type of virus this will be. There are some viruses we can get a vaccine once and you're good to go. Then there's viruses like the flu. You've got to revaccinate every year. From just what you know about how this virus acts compared to other viruses, do you have any idea what we might be looking at in terms of the future and living with COVID forever and ever?
Well, I'll start. In terms of actual developing a vaccine for SARS-CoV-2 or the virus that causes COVID, as a virus, it's a very what we call conserved virus. So its ability to mutate or do what we call with influenza shifting and drifting, it just doesn't have the same type of ability to do that. But more importantly is, what will a vaccine do to stimulate our immune system, and how long will that last? That we just don't know, and that's coming in the phase 3 trials that I discussed earlier. We're hoping at least that we're going to get protection for a 6-month period of time, but we just don't know. But as far as the virus itself and needing to change the vaccine, it's unlikely.
when we very first started looking at COVID, there was the virus that came out of China, and over the last few months, we have found that there are at least two or maybe more different strains. So it is conceivable that you may need a different vaccine for different strains, possibly different strains popping up over the next few months, years. We don't know that. So I think there's still a lot to be learned about this, and I think we'll just learn as we go.
I would agree with both my co-panelists here. We still need a lot more research on the epidemiology of the viruses that are out there and the outcomes, the question that was asked before about can patients get infected twice? Can there be different strains of this? And those are all parts of the question in terms of if we have a vaccine, will it protect us against all forms of SARS viruses? And we just don't know the answer to that question just yet.
Well, I want to thank our panel this evening. I think they've done a very good job of being straightforward and trying to explain things that are sometimes hard to get our arms around. I want to thank you, the audience, for watching. The lecture will be available on Facebook to view at any time, and whatever else, any other way that you might access your what's online. Thank you and good night.